getting the opportunity to introduce Gerald Friedland is really very gratifying. When I was an infectious disease fellow at the Beth Israel Hospital in Boston, I spent a couple of months with Jerry as my attending in infectious disease, and they were really wonderful months. He is a great physician, a great teacher, and really a great person. And I learned a lot and had an awful lot of fun. That was in the pre-AIDS era. In 1981, Jerry left Boston and as a faculty member at Einstein at Montefiore Hospital. And that was the year AIDS was identified. And he was in the midst of the AIDS and then TB epidemics in the Bronx, which we'll hear about. And then 10 years later, he moved to Yale, where he the AIDS program at Yale, and continued with his excellent work in HIV and tuberculosis. And shortly after being there, he set up a program in South Africa. And he's going to tell us about his experiences with HIV, TB, all the way from the Bronx to South Africa. Really look forward to hearing you talk, Jerry.
Well, thank you so much for the invitation. I'm really very flattered and honored. There are many, many people here who are very dear to me, so it's really a very special event. In addition to Doug, who is a wonderful fellow and exemplifies this thing that many of you in academic medicine have experienced or will, and that is that one of the great pleasures is when your students become your teachers. And that's been the situation with Doug, and I have learned so much from him over time. And so back to you. Mike Oxman, who's next to him, we were colleagues at Beth Israel Hospital and Children's Hospital, and have special places for each other. And Josh Vieira and I were college classmates. And so it goes. So I know Chip and Connie for many, many years, and Tony Cantizero is an important figure in tuberculosis, as are other people here, particularly Connie. So that, in a sense, I feel like I'm bringing coals to Newcastle. You know, that experience they use a lot in Boston. There's many, many giants here, and I'm really privileged to be among them. So this is going to be a slightly different talk than what one usually hears. It's, as I was telling Connie, at my stage of the game, I think I'm privileged to actually speak about experience and not necessarily only data-driven things, so I'm going to do that. And I've spent a lot of time with both HIV and tuberculosis in the last 30 years. And there's so many details and wonderful new things to really talk about. I'm going to talk more in general about the nature of these as epidemics, as not specific diseases or diseases with hosts, but really in the more general context of how these events happen and what the consequences of them are, and how one can put together really the sort of the genesis of compilations of disease that we label as epidemics. And I'll do that in relationship to the two that I'm most familiar with, the epidemic of HIV and tuberculosis in drug users in the Bronx, and HIV, TB, and drug-resistant tuberculosis, XDR TB, in this little place in rural KwaZulu-Natal. And what I'd like to do in the course of this is identify similarities, not only the differences between these places, which are obvious, 8,000 miles apart, and events that occurred 20 years apart, but really how similar some of those really are as a sort of broader commentary on epidemics. So this is everyone's starting point with the HIV epidemic, and you've all seen the slides, and it's sort of like the beginning. So my first question is, was this actually the beginning? And of course it wasn't. June 5th, 1981 and July 4th, 1981 expanded to what was already happening for months and more than a year in New York City and in other places, but really hadn't quite reached the radar screen. And let me explain that a little bit more. First, I'm going to rely upon I think the most important author about plagues, Albert Camus, and if you haven't read his book, The Plague, I recommend it. It really is a brilliant discourse on how people respond to plagues. And that includes all of us who've really spent our time responding to this plague. So everyone knows that pestilences have a way of recurring in the world, yet somehow we find it hard to believe in the ones that crash down our heads from a blue sky. Well, most of them actually don't do that. They mostly slip up over time. And to illustrate that, this is a hand-drawn epidemiologic curve from New York City about a year and a half into the recognition of the epidemic. Now, many of you in the room will remember that we used to do this. We used to hand draw, actually, curves on graph paper, right? If you can believe it, there was no PowerPoint. There weren't even cell phones. In fact, I don't think there were laptop computers. How did we actually function? Well, we did. And so this is the first year and a half of the epidemic in New York City. And there are a number of things to point out, which I think are relevant to what I just said. The first is a year and a half after that June 1st case. Second is, that's where June is in this epidemiologic curve, not at the beginning, but almost in the middle. And once a case definition was established, it was possible to go back and identify by chart review that actually this was happening going back into the mid-1970s, but not recognized. So there were cases that actually met the AIDS case definition in New York City that far back, and similar things have been done in other places. The other thing to note is that the largest number of cases, that is in the dark, were New York City, and that was then, and in many ways, the epicenter of the epidemic in the US. So the epidemic didn't come out of the sort of crash down on us, it sort of slipped up on us. And this is true, I think, of even Ebola in West Africa. If you look back, there were signs and reasons to know that this was happening. This is the epidemiologic curve of tuberculosis in New York City from 1920 to 2000. And these are case notifications of newly diagnosed cases, and you can see that in 1920, the rate in New York City was 200 per 100,000. 200 per 100,000. And that rate went down dramatically until the 1980s. And it was even thought that tuberculosis would disappear. And then there was these unanticipated 20,000 or so cases of tuberculosis. And they temporally and geographically and biologically were linked to HIV. So that was, in a certain sense, the recognition of this tight bind between these two diseases and these two epidemics. This is a map of the Bronx, where I worked somewhere around here. And it turns out that the Bronx was the poorest urban county in the US, and it still is. And 38% of people live below the poverty line, and I'll come back to that later. And this is actually the part of the Bronx in which the case notification rate was greater than 75 per 100,000. And it's exactly the same area where the income level was lowest, that is, between 40 to 100% of people living below the poverty line. So this relationship between tuberculosis and poverty on this sort of macro level, forgetting about nutrition, crowding, and all of those things that go along with it, is really very, very clear in this sort of portrayal, and helps understand why this was such a focus. I, with colleagues in Montefiore, appreciated pretty early on that the motor that was driving the epidemic was injection drug use, and both HIV and also tuberculosis. And we sought to sort of identify what was actually a relationship that you could quantify between tuberculosis and HIV. So this was a study that was done in the methadone program at Montefiore, looking at the risk of TB among injection drug users with HIV. These were not people who had AIDS, but actually had HIV infection. And just look at those who were known to be PPD positive. So they were identified and followed for a 2-year period of time. And among those who were HIV positive, the case rate was almost 8 per 100 person years. And the HIV negative ones, no tuberculosis. And it was true, but not as strikingly among those who, in whom the tuberculin skin test was negative. So this relationship of HIV and TB, in which people who are already infected with M. tuberculosis and then infected with HIV, of a reactivation rate of maybe 8 to 10% per year, is something that I think has been repeated many times. It varies over the course of HIV infection and over the course of actually latent TB infection, but it still sort of is held up as a number. Now, I think, as you all know, the lifetime risk of tuberculosis if you have latent TB infection is maybe 10%. So this is an annual risk and explains this confluence of HIV and tuberculosis so well. And it was there in the Bronx that we were able to do this among injection drug users in a methadone program. So I want to sort of put this together in a kind of story that I'll call The Soil, in which why this happened in the Bronx, the poverty and what was the physical destruction of the environment. During the 60s and the 70s, it was more profitable for landlords to actually burn their buildings than to collect rent and maintain them. So there was an epidemic of arson in the Bronx, with actually a destruction of the community, crowding, burnt out buildings, and high rates of latent TB infection. There was a heroin epidemic and a policy of restriction of needles and syringes. HIV entered the population in the mid-1970s, and we know this from serum that's been stored, that was stored at Rockefeller University for methadone, actually study of methadone. And by looking back when the serologic test was available, it became clear that HIV entered the population of those drug users in the 1970s, at the same time as it entered the population in San Francisco, where there was a cache of serum that was stored for men who had participated in a hepatitis B immunization program. And there too, in the mid-1970s, sera started to appear with HIV infection. So HIV arrived, and the wind, which was a cocaine epidemic. Cocaine has a very short half-life, so it's injected 4, 10, 15, 20 times a day. Heroin, a warm and fuzzy drug, is injected 2 or 3 times a day. So the need to have needles and syringes and readily available when you're picked up, if you're carrying them without a prescription, evolved to the shooting gallery, which was an entrepreneurial solution, and in which people congregated, renting needles and syringes in crowded indoor locations where TB would be transmitted. And at the same time, there's a disassembling of the TB program because New York City was in a financial crisis, so that the TB program essentially evaporated. And all of those things came together sort of at the same time in a sort of diabolical soup. And there was denial, stigma, and ineffective response, which has characterized both HIV and drug-resistant TB. So there was an explosive epidemic of HIV and tuberculosis in drug users. And this was a study that we did that looked at the rising rate of seroprevalence in injection drug users in the methadone program. And as you can see, before 1978, it was about 10% and rapidly rose to almost 50%. So that sort of explains that sort of event a catastrophic event. And I just want to leave you with that, except for the fact that there was one other event that accompanied it, and that was the actually arrival of HIV-related MDR TB. And this occurred in New York and other hospitals in the US and in hospitals in Europe and in the prison system in New York. And these were case series, and this is a group of cases. As you can see, 100% of them almost were HIV infected. The mortality rate was extraordinarily high, and the median time to death was about 8 weeks, and you can see here sort of the range. So that this was a new event accompanied or related to HIV with very high mortality and a very high rate of mortality very, very rapidly from the time of identification. We'll hold on to that and come back to that. So just to remind you, I think everyone in this room probably knows, but just for those who might not, these are the first-line drugs and these are the second-line TB drugs, and MDR TB is resistant to isoniazid and rifampin or rifabutin. And there's still many treatment options, but the treatment takes 2 years. It consists of an injectable. It's really extraordinarily difficult with not very good success rates, some in the range on the average of 50%, and very common loss to follow-up among those who have to endure it. So I want to move to New Haven, where I moved with the same situation in injection drug users and kind of advertised what was a response to the epidemic of HIV and tuberculosis in injection drug users, and that was needle exchange. And so New Haven was one of the first places in which needle exchange or needle syringe exchange was actually legally developed. This was the needle exchange van. It was a form of police van. And it made a very, very important point about finding hidden populations who tend to avoid or have no access to the traditional healthcare system. And what we learned from this is that if you really want to do this kind of work, be it here or in Tugela, Ferry or in San Diego or in Mexico, you have to go to where people are. You can't wait passively until they come, and you have to develop outreach, community-based type work. So this was what was done in New Haven. Here's the needle exchange van, and here's a large community healthcare van. This is Rick Altice. Do any of you know Rick Altice? He's driving the van, as you see, which follows the needle exchange van and adds healthcare screening, HIV, HCV, TB screening, actually can provide directly observed therapy on the van, isoniazid preventive therapy, and substance abuse referral and treatment. And this has become a very, very important part of the healthcare system in a small city, poor city, with lots of injection drug use and an important way of reaching out. The other thing, of course, that was done was prison health, and I won't have time to talk about that. So what was the lessons, so some lessons from New York City and New Haven? Sudden unexplained appearance of HIV and TB are not sudden and are explainable. So there's an issue then of how do you know when something's happened before it explodes, and one of ascertainment. And I think first lesson, I think, would be, which has happened now, there are systems for developing and for identifying new events, new infectious diseases, but they're imperfect. And we've had clues for a lot of them that we didn't pay attention to. The critical role of poverty and marginalized populations, of hard-to-reach populations, continues, remains. I heard it in the presentations this morning. The TB-HIV connection, the drug resistance, and the need to outreach and focus on hard-to-reach communities. Here in New Haven, needle exchange, prisons, drug treatment programs, and also opportunities for combination of integrated strategies for prevention and treatment. So that's, I think, in a general way, filling in the details with new diagnosis, treatment, and all sorts of things that we've remarkably developed in the last decade, I think goes along with this, of course, but I wanted to point this out as well. So the global TB situation, it's estimated that in 2013 there were 9 million new cases. The estimated number of deaths were 1.5 million. HIV-associated TB thought to be 13% of that, with maybe 360,000 deaths, and multi-drug-resistant tuberculosis, 500,000. 3.5% of new cases of tuberculosis, drug-resistant, and 20% of retreatment cases. And it sort of depends upon where you are in the world. But since most cases are new cases, that 3% actually becomes the vast majority of transmitted cases of tuberculosis. That is, the etiology and numerically of new cases being recently transmitted has seen drug-resistant cases with primary, with the first treatment. And as you can see, this estimated number of deaths, and 9% of those are XDR TB. Well, it's always sort of hard to look at these numbers and sort of grasp them. And so I have a few things to show you. So this is New York City, the population of 9 million. And this is the number of new cases globally, the size of the population of New York City. San Diego has a population, I learned, of 1.356 million, so I'm calling it 1.5 million, which is the number of TB deaths. The population of San Diego. HIV-associated TB, 1 million estimated cases, that's Philadelphia. And MDR TB incidence, I went to Connecticut, and Connecticut City is small, so you have to put them all together. But you can do that, and it comes to about 500,000. So these are real-life places with real-life people, and not just numbers. And I learned when I was at Montefiore from a guy named Ernie Drucker, some of you might know, that statistics of epidemiology are human beings with the tears removed, and something that we need to remember. So these are the estimated TB incidence rates globally. Many of you have seen this, and you know that 22 countries account for 80% of the global burden. And its greatest numbers are in Asia, and China, and India, and sub-Saharan Africa. It primarily affects the most economically productive group. So like HIV, it has enormous economic consequences, not just health consequences. And social determinants are linked to poverty for both diseases. This is the HIV notification rate, 100,000 in South Africa when this was done. Does anyone want to volunteer what the rate is in the US? Right. Okay, so here we are living and talking about TB, but it's like HIV, really the full force of it is not here. Not to say that we shouldn't be concerned about it. This is the estimated HIV prevalence among new TB cases globally. So in this instance, in the US, it's 15%. Anyone like to hazard a guess as to what it is in sub-Saharan Africa? 85. Okay. That's good. Okay. Excellent. Again, you see the difference and how important sub-Saharan Africa becomes as a point of confluence for these two diseases. So some of you have seen this. It's a slide that I borrowed from Salim Abdul Karim. It makes a very, very important point. So this blue represents the epidemiologic curve of HIV as measured by antenatal seroprevalence and surveys. It has the same shape and almost the same timing as the epidemiologic curve in injection drug users, as I showed, with the HIV prevalence actually being quite low in the early 1900s and rising dramatically to over 30% now, even higher. And this is the TB rate, 200 per 100,000. That would be in New York in 1920s. And then HIV arrived. And TB took a little while, but then it exploded because this difference, this didn't happen immediately, is the population-based immunosuppression that follows the arrival of HIV. And so in rural KwaZulu-Natal, where I work, TB is considered the mother of AIDS. Very graphic, because oftentimes the diagnosis of HIV is made when someone presents with tuberculosis. So, like other people, I was attracted to work in Africa where the forces of both epidemics were. And I thought that integration of HIV and TB was a worthwhile thing to try to attempt to diagnose, initiate treatment, monitor, and improve the outcomes of both diseases. They're being so closely connected. They're low-tech diseases. We don't do a lot of surgery. We don't do a lot of invasive procedures. We really diagnose and give pills. Treatments are good, except for drug-resistant TB, and medication adherence is critical for both. So it made sense that these two could be put together. But there were challenges. I think the most important one, which we know about when we work in both fields, is the different traditions. They're in parallel with each other. TB is a very top-down, hierarchical disease that the organization of which is, and had been, at least at that point, determined by old men with gray hair, right? And HIV has a different history. It has a history of human rights and much more energy, and men and women, as in this room. It's very hard. The cultures are different. Concerned about paradoxical reactions, IRIS, as you know, additive side effects and toxicities, drug interactions, and great concern about disruption and overburdening of the TB healthcare system, because the idea was to first do this integration in the TB programs, because they already existed. But we tried, and so the first study, and these are 3 studies that I'm just going to mention very, very briefly, something called the START study. There are a lot of START studies. This is in an urban clinic in Durban, and the idea was to assess the feasibility and effectiveness of integrated strategy. And then the CAPRISA START, which became SAPIT-1 and SAPIT-2, and there's a SAPIT-3, which was done by colleagues there in Durban, and a study in the rural area of Tugela, Ferry, which I'll tell you more about. So the START study was done in a TB clinic, and I think back to that time, and these are things that we wouldn't, well, we could appreciate now, but really thought that it would be difficult to administer HIV drugs in a TB clinic because everyone in a TB clinic takes the same medication. And if someone was taking different medication, they would be identified as having such different disease. And they would be identified as having HIV. And this was a time in which that would be, HIV was much more stigmatized than was now, and it is now. But it turned out to be the opposite, that there were very high levels of acceptance of the strategy of patients and staff. And counseling for HIV was readily accepted. And I learned that, and during that episode, that in a disease in which relatives and friends and loved ones are dying, treatment trumps stigma. And although stigma exists and is powerful, the availability of treatment for HIV has had a dramatic effect on stigma. Antiretroviral, these are 2 women obviously taking both their HIV and TB drugs in the HIV clinic, in the TB clinic, and it worked very well. And the idea then, having done that, was to move it on forward to develop the START study and the SAPIT studies. And so the SAPIT trial was the first one, but there are others to report on the integration of TB and HIV in a randomized control trial. And the question here, the first question was, do you do it at the same time or sequentially? And SAPIT showed very, very clearly that using mortality as the primary endpoint, that you could lower mortality, 55% lower, by treating tuberculosis and HIV at the same time. So the mortality rate per 100 person years in the integrated arm was 5.1, the sequential arm was 11.6. That was highly significant. The studies that followed, both in South Africa, as it was designed, and in Cambodia, and a ACTG trial, which I'm sure Connie had a lot to do with, looking at when during the course of TB therapy do you start antiretroviral therapy, all came out quite remarkably in the same issue in the New England Journal, boom, boom, boom. And although they had different populations and very similar designs and some difference in nuance, I think the message that came out was really very clear, that in people who are severely ill, CD4 counts are very low, and as I'll mention other things, that antiretroviral therapy is life-saving. And although we worry about iris and all sorts of other things, mortality trumps that. So they all came to the same conclusion, and I think it was a remarkable tour de force to answer this question. There's still debate about it, but I think we're all pretty convinced that the right thing to do is to treat as reasonably quickly as you can. So these are the Department of Health and Human Services guidelines that are in the ART guidelines, that is when to start ART in TB. When the CD4 count is less than 50, initiate within 2 weeks. When it's more than 50, we actually did something a little bit more. We went beyond the CD4 count, but really to try to assess what is the severity of the disease that the patient has, not just the CD4 count. The CD4 count is a measure, but if you have the opportunity to do it, you should really look at the patient. And a low Karnofsky score, a low body BMI, low hemoglobin, low albumin, organ system dysfunction, extent of disease, are all measures independently of mortality. And therefore, they can stand, as does CD4 count, as an indication for early treatment. So that was recommended. For others with a CD4 count over 50 who didn't have any of these characteristics, you can wait. Although I think most people now operationally will just go ahead and treat in the same way. And that's what my colleagues do in South Africa. So the next step in this sort of odyssey was to see if this kind of a strategy would work in a really deprived, resource-poor rural area in South Africa. And all roads led to this place called Tugela, Ferry. It's about 2.5 hours north of Durban. It's a very beautiful area. It was a part of Zulu homeland during apartheid, so it's really resource deprived. There's one tarred road. There's a population of about 180,000 to 200,000 people. It turned out, although unbeknownst to me, when we started working there, that it's the poorest sub-district in all of South Africa, much like the South Bronx, by all the usual measures, electricity, education level, unemployment, availability of water, et cetera. With a very high HIV and TB burden, a case rate of TB of 1,000 per 100,000, a high antenatal rate, a government district hospital called Church of Scotland Hospital, although it's been a government district hospital for 50, 70 years. Every time I go there, I expect that it's going to have a Zulu name, but it hasn't happened yet, but it will. An NGO, Pilanjalo, and very importantly, a laboratory at the University of KwaZulu-Natal that was doing second-line drug resistance testing, and one of the few then at that time on the entire continent. And that was a guy named Wim Sturm who understood how important that was. And so that was the context. And there we did a study called Sizankolba, which in Zulu means we shall conquer. We translated that into we shall overcome. And another lesson was to try to contextualize where and how you treat people. So I learned that Zulu culture, things are done collectively. You don't make independent decisions. You make decisions collectively, and you don't do things independently. You consult with the chief, you consult with the family. So why not have people construct their regimens together? and take them together. So this is the origin of the adherence club. And these are women sitting around a table with all their pills, and they're putting them into a monthly calendar. These are non-literate Zulu women talking about their husbands and boyfriends and children and all of that, and making up their regimen and incorporating it into their life. And it worked very well. Viral loads went down, CD4 count went up, and we were aiming for a mortality of 5 or 6%. It was thought that in the first year, mortality would be 40%. That was the historical figure of HIV and TB co-infection. But it was about 10 or 12%, and started looking at what were people dying of, and had the opportunity, because these specimens were saved, to look, and it turned out that almost everyone who died of XDR TB. And we learned that actually on a conference call with South African colleagues, and they're going through the cases, and each one had XDR TB, and honestly felt the lights went on or went off, and faced with another catastrophe. And so in the following year, we found 53 cases of XDR TB. They were all HIV positive. 98% died rapidly, as you can see. Remember how they died with MDR TB in New York? It was the same thing, and the mortality was extremely high. And the Lancet was very excited to actually publish this, because to their credit, they recognized it was very important and a game-changing sort of event, as it turned out to be. So failure to act now to contain the threat posed by XDR TB will have devastating consequences for patients with TB, particularly those co-infected with HIV. So just to, in case you're not familiar, this was MDR TB, this is XDR TB. The fluoroquinolones and the injectable drugs are resistant, so the options are very, very few. Actually, almost always resistant to pyrazinamide and ethambutol and streptomycin as well, and you're not left with a whole lot. The treatment's very long, and the cure rates, treatment success rates, maybe 20, 25%. This is a very, very bad disease. There was also evidence for nosocomial transmission. Most of these people had not been treated for TB before. Many of them had been hospitalized at the same hospital in the past 2 years. There were healthcare workers who died of XDR TB, and there was genotyping available, and it showed a very similar strain, which came to be known as the KZN strain, or the LAM4 strain. And RFLP genotyping revealed that this was, they were almost all the same, and so this was a clonal event, and supporting the idea of transmission and nosocomial transmission. Subsequent studies by my colleague Neil Gandhi in much more detail really made this very, very clear. So this is the hospital over time, and these are individuals who were on the wards of the hospital who had XDR TB undiagnosed and unrecognized, because the diagnosis was mostly made at that time post-mortem. So there are 113 patients hospitalized before the diagnosis was made. And there was one patient with XDR on the TB wards for 91 days, 91% of days during that time. And as you can see, there was tremendous exposure to XDR TB, and the mean patient days of exposure for those patients are about a month. So there was this intensive pressure cooker bouillabaisse of XDR TB on the TB wards. And it became very clear that this was, we already knew about this, but this had put it together and shown that how important nosocomial transmission was. The other thing that came out, which wasn't so clearly understood, was that there was good evidence for exogenous superinfection. So it used to be thought that if you're infected with TB, you can't get infected with another strain. And that was the mantra then. But in HIV patients and others, it's now clearly known that you can get superinfected with tuberculosis. So here's individuals who came into the hospital with a case of tuberculosis, and with a whole batch of different spalagotypes, got better, went out, got readmitted, and their tuberculosis then was almost all of one spalagotype, ST60, which is the lamb Tugela Ferry strain. So it was clear that they picked it up either in the hospital or in the community, but it was a superinfecting event. So this is what it would be like clinically. Here's someone with tuberculosis, right lower lobe, gets treated, does well, goes home, comes back several months later with a new infiltrated in a new location. It turns out to be XDR TB, and he dies. It's a very terrible, terrible, difficult situation, as you know, because XDR TB is transmitted so differently than HIV, and everyone was at risk in the hospital. So over the next several years, a total of almost 700 drug-resistant cases, XDR, close to 400, occurred in this tiny little place in rural KwaZulu-Natal. And it became KwaZulu-Natal's town of death. And the press really was terribly irresponsible, as it had been in the early era of the HIV infection in the US. And people were afraid to come to Tugela Ferry and to work there. So I want to say that I think that what we were seeing was only the tip of the iceberg, and there was much, much more that wasn't apparent. And here's a reason to think that. So this is MDR, not XDR TB. But in KZN, during 2006, there were 686 people who were diagnosed and treated at the referral hospital for MDR TB, but there were 3 times as many people who were diagnosed but never treated. There was only one source of drug. So that these individuals were diagnosed but never made it to treatment, probably died before treatment. And then there were people who were probably seen in the healthcare facilities but never had a culture taken and diagnosed. And then there were people who just died in the community who no one ever knew about but likely died with drug-resistant TB. And there have been autopsy studies that have shown that when people die without a diagnosis and do an autopsy, many of them have TB or drug-resistant TB. So, how did this happen? When did this happen? What actually brought this to bear? Where did it come from? So this is a very interesting study done by Wim Sturm and Cookie Pillay. And these are increasing collections of of tuberculosis drugs, but with resistance. And here's 1994, and these are just isolates, so it's not really an epidemiologic study, but a sampling of specimens that came to the TB referral lab. And here's an organism with no resistance, but also one resistant to isoniazid and ethambutol and also rifampin. And as you can see, as the years go on, more and more and more organisms are identified resistant to more and more and more drugs, until finally what was defined as XDR TB appeared in 2001. Then there was no funding to do any more drug resistance testing, and then the 2005 outbreak or epidemic that we described was described. So all of this was happening through all of this time, and there's a lot of other examples now of why that was the case. So first of all, let me say that Tugela Ferry was not the only place where this was happening. This is Tugela Ferry, 34 per 100,000, 207, but all these other blue dots represent, in scale, the number of cases of XDR TB were isolated. Remember also that people weren't looking. So there was an ascertainment issue, whereas in Tugela Ferry there was heightened awareness, and every patient with tuberculosis had second-line drug resistance testing. In 2010, the 10 to 12, the rate in Umzanyati, or where Tugela Ferry is, declined very dramatically, and all these other places had increasing rates. So that in KwaZulu-Natal, there is this sort of rising level of XDR TB and not just in Tugela, Ferry, and as we had sort of predicted, because the circumstances were right in so many different places, that this would be the case. And they fell in Tugela, Ferry, and if time allows, I'll show you why. So XDR TB was isolated from 60 other facilities in KZN. This was the estimated MDR and XDR underestimate, I believe. There were cases found in all 9 South African provinces, 1,000 cases in 2005 of XDR and 18,000 of MDR. In neighbor countries, Botswana, Mozambique, Lesotho, Swaziland began to report cases, but the full extent is unknown, and I think remains unknown. We don't have denominator information for any of these, although there are now surveys that are being done serially around the world, and we'll have much more information. And there is this survival bias thing that you only know about the patients who have a culture. And those who never get cultured but have the disease never actually get counted. And culture and drug susceptibility testing is limited, although that's improved enormously, as you know. This paper was just published a week or 2 ago, and it's from Durban with a huge collection of XDR TB isolates from a lot of different cohorts with whole genome sequencing and looking for resistance and compensatory mutations and estimating their frequency and time and when they were introduced in relation to when TB drugs became available to try to figure out what happened in Tugela, Ferry. And what was discovered was it's likely there was an ancestral precursor LAMP4, the XDR strain, which first gained mutations to first-line drugs in the 1950s. And then there was subsequent accumulation in a stepwise fashion in this way of all these other mutations to all these other drugs. These are years, I can't see it too well, and these are when the drugs became available, and with each one there would be a mutation or mutations that would confer resistance, and then ultimately the XDR LAM strain occurring. So this was a stepwise event happening over decades, and everything else I think that I've shown you indicates that this was not coming out of a clear blue sky. It was percolating along, but unrecognized. Much like what we talked about in terms of tuberculosis and other things in the Bronx. So the soil here was a high prevalence of MTB, 200 per 100,000. Weak TB control program, low cure and completion rates, previously treated drug resistance, again, extreme poverty, absent microbiologic surveillance and empiric treatment being done, so that there was really no way of knowing this was going on because no one was getting cultured. The seed would be the KZN strain with the sequential accumulation of resistant mutations and amplified drug resistance and an array of compensatory mutations which seem to provide the organism with restoration of virulence. And as it used to be thought that drug resistance and tuberculosis, the organisms were weakened and they were not as infectious and you didn't have to worry about them. But what this study and others have shown is that actually the organisms develop compensatory mutations which allow them to actually start replicating and doing what they do as they had done before they had drug resistance. The arrival and progression of HIV, massive increase in TB cases, increasing population and individual immunocompromised, rapid progression to disease, new and transmitted drug resistance, over-reliance on hospitalization, absent limited infection control, and nosocomial and community transmission. And this is what happened with XDR TB in Tugela, Ferry, and this is XDR, black is MDR, and this is the total. And as I mentioned, this sort of epidemic curve that looks like HIV and TB in the Bronx. So I'm not going to talk about MDR XDR in the rest of the world. That's where most of the diseases actually in Asia, but in confined myself really to sub-Saharan Africa, but I think you all know that MDR XDR TB is a global phenomenon now, and there have been over 100 countries reporting XDR TB. The true incidence and prevalence, I think, is limited still by lack of lab capacity and the survival bias issue that I mentioned. And most are probably not diagnosed or treated. So here we would say what we're seeing is the tip of the iceberg, right? But in South Africa, they call it the ears of the hippo. Well, so here we are in the midst of this catastrophe. What do you do? So the KZN Department of Health was actually excellent and responsive. The NGO that we work with was excellent. And US and South African academic institutions and investigated formed a collaboration, which we call TF Cares, and we elaborated a lot of different interventions, not sequentially, but all at once that we could think of to try to confront this epidemic, and I'd like to describe a few of them. What came of that effort. So first was strengthening the TB DOTS program and resources for interventions. And the TB program was massively refunded. Improving inpatient, outpatient infection control, integrating TB and HIV diagnosis, care, and treatment, initiating antiretroviral therapy, reducing reliance on inpatient care and focusing on patient-centered, community-based early case detection, treatment interventions. So this was sort of the range of interventions. So this is just to illustrate that the Department of Health actually stepped up and really did. So these are the number of enrolled nurses over very soon after the outbreak, tracing teams, vehicles, and it extends all the way through. So, and you could see some of the benefit because the treatment success for TB improved dramatically, significantly. And the deaths from TB came back a little, but nevertheless not to where it had started. So the TB program was strengthened. Transmission of MDR and XDR TB. So this is the TB wards in Tugela, Ferry, the general clinic waiting room, another area of waiting room, and this is where actually people waited to be seen in the ARV clinic. You can imagine about 20% of them likely with active tuberculosis. So it became very clear that an infection control program needed to be developed, and how do you do that? Well, there were no policies in KZN. So a medical student spent some time there and worked on developing policies, and they were intelligent, and they were based on WHO and CDC guidelines. And they were the first policies in practice in KZN, and they were actually disseminated to other places, and they were adapted to the local environment. Identifying and separating MDR TB suspects by the new job category called a cough officer. So what is a cough officer? It's someone who sits at a desk at the entrance to the hospital and asks you if you're coughing. And if you do, you go through a different queue and you get evaluated. And the idea was to keep the hospital as best you could to decrease it becoming an incubator. Sheila Shenoy, my colleague, organized that. Performing facility assessment and improvement and enhancing natural ventilation. I'll show you that. Protecting personnel, reducing reliance on hospital care. Trying to monitor and evaluate, and then moving all of this into the community. So the first thing we did was actually assess air changes on the TB wards. So if you close all the windows, and they put in mechanical ventilation, but and it worked, but as you know, mechanical devices don't get serviced very well, or there aren't spare parts, et cetera, and they lose their value over time. So if you close all the windows, you get 1 air change per hour. So the air just sits there. And if you're in any of these beds and someone has XDR TB and they're floating droplet nuclei, everyone's going to inhale them. If the windows are closed and mechanical ventilation, 15 air changes per hour, that's pretty good, but the issue is, will it be maintained? And if all the windows were open and mixer fans were put on, this was our measurement, 60 air changes per hour. Is it always 60? I think the wind was blowing very well. You can't do this in Siberia probably, but you can do it in sub-Saharan Africa. And people say, well, it's cold 3 months out of the year, so you do it for 9 months out of the year. That's better than not doing it. You know, behavioral interventions are never 100% effective. But so, Pat, we learned about natural ventilation. Here is screening TB patient at the entrance points to the hospital. So as you see, it's actually going on, and you pick up coughers, and we found that in the outpatient clinic, 6.5% to 10% of coughers were smear positive. And they got separated, and this is, Gene Expert has helped a lot with this now, as you might imagine. Facilities improvement. Well, the Department of Health provided a new clinic, and the clinic is wonderful. As you can see, it's well ventilated, and air changes per hour are fine. And personal protection, N95 respirators, staff screening, all new staff screened for TB and HIV if they're willing, followed screening monthly, encouraged to know their HIV status, and relocated if they had HIV. It's easier said than done because that's a stigma associated with being relocated. But that was the policy was put in place. I think what turned out to be most important is to establish a culture of good infection control. So this again is a behavioral cultural thing. And if you work in hospitals or if you work in a medical facility, you know that there's now a culture of infection control that didn't exist before. And there are gloves and there are places to put needles and syringes, and everyone has to do it. So you'll find that the windows are open. People have N95 respirators. Doctors have them as well. And it turned out that even the women in the laundry were wearing N95 respirators. And that's probably not necessary, but it's part of the culture. So if you weren't wearing it, you weren't cool. So it's hard to maintain this, but it shows that it's possible to do, I think, and very, very important. So the hospital becomes a place where there's a actually culture of infection control. So how do you measure this? And how do you determine whether it's done anything? Because, you know, infection control is extremely important, but we really don't know how to study and measure it. I don't think there have been any good randomized controlled trials. So we cooked up a few measurement strategies. The first was modeling with our modelers. So we looked at all the various things that you might do and what effect that might have in the models that were constructed, and learned from this that you could almost reduce half of the anticipated cases of XDR TB if you had a combination of 5 or 6 different infection control strategies. So the message here is combination rather than single, just like combination therapy and combination prevention. And so that's modeling. It's not fact, it's not empiric, but it makes sense. Then we developed this environmental monitoring by measuring window open and with unannounced window opening measurements. And these are male and female wards, and someone would come while no one's looking and just count the number of windows that are open, and as the numerator and the denominator, total windows, and give a grade and then present it back. So this is not rocket science, but it's implementation and monitoring and supporting a very important intervention. And every February, there's a point prevalence done on the TB wards of MDR and XDR TB. And these are the proportion of TB cases that are drug resistant. And you can see at the height or the depths of the epidemic, 60% were XDR or MDR, and that has fallen dramatically. In the last several years, we haven't detected anyone. But it's very interesting because if you use Gene Expert, you find them. So an important use for expert is actually as a tool for nosocomial screening for tuberculosis, not the way we usually think of as someone who's going to be tested to be treated for tuberculosis. And so they were there, but below the level of detection of what had previously been available. You can see the dramatic decline. Antiretroviral therapy, probably with infection control, the most important thing. So this tremendous increase in numbers of people on antiretroviral therapy, and I'll leave this for later, but as you can see, dramatic increase. And with, I guess I should say, this is the epidemic curve of XDR TB, and as you can see, there's an association. I wouldn't call it causation. They go in opposite directions, and with a negative correlation that suggests that maybe they are related. Antiretroviral therapy, less drug-resistant TB. And then it became, I guess I won't have time for questions. Is that all right? I have about 5 more minutes. Yeah, plenty of time. Okay. Okay. It became clear that working in the hospital was not sufficient, and that you really had to, like with drug users or with other hard-to-reach populations, you had to go where they were. And we did some modeling that made it clear that if you wanted to avert epidemics of extensively drug-resistant tuberculosis, you had to shift efforts to community-based, not just hospital-based efforts. And this was part of a model that was drawn that indicated that into the future 5 years, there'd still be lots of nosocomial infection, but if it was attended to, that the majority of cases would be transmitted in the community. And enough cases with XDR TB survived, even though the survival rate was only about 15% after 4 or 5 years, that it was possible to construct a case control study, a retrospective case control study of survivors and those who didn't survive, and see if we could tease out what kinds of things might have been associated with survival among XDRs. So blue is smear negative and green is smear positive. So if you were smear positive, your likelihood of survival was much lower. If your CD4 count is much lower. And if you had an index of disease severity in which different organ systems here counted were dysfunctional, each going down from 1 to 4, with each successive one, your likelihood of survival would be diminished. And these are individuals with XDR TB who had no organ system dysfunction. So the issue is severity of disease, not just whether you have XDR TB, but when in the course of treatment you identify someone has it and does something about it. And one of the things that can be done is antiretroviral therapy. So it made it very clear that we had to identify people earlier in the course of their disease and not wait until they came to the hospital. I think this is a very good demonstration of the cost of not doing that. So this array of community-based strategies are developed: prevention, isoniazid preventive therapy, infection control, early identification, getting into care, community-based treatment, and then, because this was in the PEPFAR era, it wasn't research, it was evaluation, right? And measuring, but we studied it. So community-based intensive case finding, household contact tracing, this is sort of what the environment looks like, and these are household contacts of an index case, and it's a very high yield. And it turned out that among the index cases, the mortality was 82%, but among the household contacts, 57%. So again, it makes the point that if you get people early and not wait until they come to the hospital, you can possibly influence mortality. And then we developed this community intensive case finding program, which Sheila Shenoy runs, in which people are screened in the community at various congregate settings where people come together. It's a very dispersed population living in small family compounds, maybe 15, half an hour, 3/4 of an hour away from the next one, and it's very hard to do household contact tracing, or intensive case finding, although we're doing it now. We demonstrated feasibility and found a lot of HIV and a lot of people with TB. I'll skip that. And this very interesting thing has emerged with other people have demonstrated and shown, and that is that there's a difference in the TB cases that you identify in hospital settings and in the community. And the difference is the HIV prevalence among those individuals. So in the hospital, 64% of people are HIV co-infected, but in the community, only 12%. And so this has been pointed out, and it probably means is that people with XDR TB who are not HIV infected live longer. They have an opportunity actually to transmit for longer periods of time, and they don't come to the hospital because desperately ill as if they have HIV infection. So it makes the point that that screening efforts and the whole enterprise has to be directed not just to co-infected individuals, but individuals who are not co-infected with HIV, because they are probably the major core of transmitters. HIV patients die. And we've measured air exchanges in traditional homes. These are the two kinds of homes. I won't, in the interest of time, go through the air measurements except to say that if you close the windows, you get in about 2 hours, likely a 20% likelihood of getting infected using a Wells-Rayleigh equation. If you open the windows, you still get infected, but it takes much longer. So this is a conundrum because we want to improve the environment of people, but actually if they stay in that environment, and you don't actually identify patients and get them out, they're likely going to get infected. But it does make the point that the same principle applies, and that natural ventilation, if it was applicable in Zulu huts, would work. But not by itself. And community-based treatment of drug-resistant TB. So this is where people in KwaZulu-Natal have been treated for XDR TB. It's a tertiary care hospital, so to speak, in Durban. It's now called King Zulu. And it would be the only place where you could get treated for MDR or XDR TB. And we felt that this is where we need to be and figure out a way of treating people there. This is the rate of admissions to the hospital with XDR and MDR TB, clearly overwhelmed. And even recently, a waiting list of people to get beds or new outpatients waiting for treatment. So we have a population of people with known diagnosed MDR, XDR who are still not getting treated. So the idea was to decentralize the program and create programs in the community that could treat MDR and XDR. And this is the first one. It was at a hospital that had closed and near Tugela Ferry, and it worked. And patients are hospitalized for a short period of time. They're close to home. They go home. They get visited by a nurse on a daily basis who injects them in the butt and supervise the administration of their MDR TB treatment. And the study published fairly recently compares treatment success in HIV-positive people in the hospital and in community-based sites, and you can see a significant improvement. And also, to the point, compares default. And the default rate from treatment is significantly lower, as you might imagine, in the community compared to the referral hospital. So this particular sort of pilot program has been adopted as the national standard now in South Africa, and they're being opened up all over the country. And lastly, in modeling studies that we've done, I think we can show that there is no single intervention that actually, this was really the combination of a whole array of different interventions that you might use in the community. They all have some sort of role, but really you see synergy when you put them together, and the idea is to figure out which combinations of them actually offer the greatest benefit in terms of impact. And these are gene expert, decentralized MDR, treatment expanded ART coverage, cure rate of drug susceptible TB, 36 months of IPT we've done now, lifelong, and a number of other things. So the message here is combinations of interventions. And this is what's happened in Tugela, Ferry over the course of the time that I've been talking. So this was the height of the epidemic, and XDR and MDR have come down very dramatically and significantly. And what we're trying to figure out now is whether that had anything to do with all these interventions, or if it did, what components of it, and how much of it is the natural history of an epidemic, and how much of it is one or several of the interventions. And I hope that actually will show a combination of interventions plus a natural history that has actually had a benefit. So this is a small place in the middle of nowhere, and it's not the global tuberculosis, but I think what the message here is that even in a resource-limited setting, if you put things together and you figure out how to do things and you have the resources, you can do great things. And so it, I think, represents a kind of a model or a way to demonstrate that it's possible to do it, and it's up to others and some of you guys to really scale it up. So lessons from New York City, coming back to the Bronx and New Haven. Well, sudden unexplained appearance of HIV and TB, not sudden and explainable, I think, in both places, including drug-resistant TB. Poverty, marginalized, this is the Bronx, but it's also in Tugela, Ferry. Drug resistance, outreach focused and hard-to-reach populations, not so much this, but this, and opportunities for combination. So, I think I just said this. What we've learned is the collision of TB and HIV was almost inevitable. And you can put things together and address it. But I think it's also, I think we have to understand that if we think we're going to actually end TB, which is the goal for 2050, then we have to address the underlying roots of these epidemics, which still remain poverty, inequity, health disparities, and I think these are still at the root of HIV and TB epidemics. So I think Albert Camus should have the last word, learning from the early HIV/AIDS epidemic, and I would say TB. So we might try to explain the phenomena of a plague, okay, which is what I've tried to do, but above all, we should learn what it has to teach us. And I think all of us would agree with that AIDS, tuberculosis themselves been magnificent teachers. Thank you.
That was a beautiful talk, Jerry. Thank you. I was struck by many things, but one of your last slides on treatment success with MDR and XDR TB in your outbreak story. The number you get to is 60%, which is the same number we've been talking about success, treatment success with MDR TB for 3 decades. And I'm wondering that it seems to me that the bulk of what was gained in the efforts that you were able to put together under extraordinary circumstances was being able to make that transmission rate go down to 0 with all of those efforts. What we haven't yet been able to achieve is making that treatment success rate number improve.
Okay.
And I think that maybe shows us the limitations of our treatments, irrespective of all of the things you were able to put together to control the epidemic. What would be your thoughts on that?
Oh, I absolutely agree, and we're fortunate in that finally, after 50 years, we have some new TB drugs, which we know are very active against MDR and XDR TB, and we're all very impatient for them to be widely available. I think you're involved in doing a number of studies with bedaquiline. I've had a little bit of experience with it. This is an exciting, revolutionary thing in the TB world. Characteristically with TB, it sort of moves at the speed of the replication of the organism, right? As opposed to HIV, but it's moving. And I think we will have tools, and I think once those drugs are available, and maybe, and it'll have to be a combination, not just a single drug, as we all know, because then we'll lose it, then I think we'll both shorten the time of treatment and have more potent drugs than we've ever had to treat MDR and XDR TB. So I expect that the cure rates will, and the treatment success rates will improve dramatically. I think as one additional comment, I'm very worried about the adherence issue with these drugs, because everyone focuses on the fact that we have these exciting, spectacular new drugs, and therefore that will solve the problem. But we know that if they're not taken well, then we'll lose them. And there needs to be more effort in the TB world, as it has been with HIV, in considering ways of improving, enhancing adherence other than the sham of DOT, right? So that should go along with the use of those drugs. No, I agree completely.
Tony.
I really enjoyed your presenting the story in Bronx as well as in Tugela Ferry, and emphasizing the soil, the wind, and the seed. And I wanted to ask you to consider one more element, and that's what I would think of as water, and that's the TB control program. TB is different than other diseases in that it requires kind of a political element, which we call the TB control program.
Right.
In the Bronx, this was particularly a disaster during the 1990s, when there was only, because of the Reagan political policy, the health departments were given a bunch of money and said, you do the best you can with this. Right. And because of that, a lot of the money was given to other programs, and TB programs were funded very low level, and there was only one public Bronx. Yep. And the treatment success rate or completion rate was less than 10%, yep. Which was the stage upon which all these other factors were added on. And I think in Tugela Ferry it's the same sort of thing. The TB control program in South Africa is very poorly funded for different reasons, but it's still an element that really.
No, I agree, and it was, as I mentioned, the first thing that was intended to was to try to strengthen the TB program. It's South Africa, wherever we are, it's a public health responsibility. We can advise, we can do studies, but ultimately it has to be done by the political process. And so, but I'd have to say that KwaZulu-Natal, probably because of the importance of one particular person, Bruce Margot. I don't know if any guys met Bruce. He was a dynamo who took it on, and which it often takes. And the provincial government was tremendously responsive, as best they could be. So I think, and that's part of the reason for the success. But you're absolutely right. Yeah.
One more question.
That was. I really appreciated the presentation, and it was incredibly educational and compelling in making the case for integration of HIV and TB care. And I'm wondering, what is your advice for programs that are parts of the world where HIV and TB are still highly siloed? How do we get those two to work together? What recommendations do you have for that?
Yeah. Well, it has to be done at all levels. It can't just be done at the local level. It has to be done in the Ministry of Health. And it really starts there. And because they have separate ministerial posts and separate funding streams and separate everything and separate philosophies. And I think it's happening. You see it happening, but it's certainly not universal. There's a lot of investment in your job and your silo. And I think this would be a role which has not been very similarly powerful in the TB world for activism. And I think if this was happening here, you'd have people in the streets and a lot of noise. And So if there was an activist community or a patient-related community, and there is some, but not enough, that could actually get on this, that would be very helpful. WHO recommends all these things, but they don't actually implement. Yep.
Well, I'd like to thank Jerry for giving a truly terrific keynote speech, and it was really a great talk. Thanks.
Thank you.